Thank you. All right. So thanks everyone for coming today. We're going to run through introductions and some housekeeping, and then we'll get right into the Q&A. So I am Amanda Lee. I'm the rate setting coordinator for the Office of Main Care Services, and I'm hosting this call today with several of my colleagues at Main Care and ODES. We will introduce everyone. This meeting is being recorded. It will be posted to our rate reform website by the end of today or by tomorrow morning, so that anyone that isn't able to attend today will be able to watch that. We're going to link the rate reform website into the chat for everybody. In order to make the most of this time, we're not going to be discussing the NF rate reform model or rulemaking process. This is for providers, their billing staff, or vendors to ask questions about the new case mix system and billing the nursing component of the patient-driven payment model. Any questions we cannot get to today, we will follow up in an FAQ or direct email to all of you. Okay, we're going to run through introductions, and we'll start off with Amanda Nelson.
Hi, good morning, everybody. My name is Amanda Nelson. I apologize, my camera is not working, having some technical difficulties. I am the Long-Term Services and Supports Initiatives Manager with the Office of Aging and Disability Services. Thanks all for joining.
Dwayne?
Good morning. I'm Dwayne Parsons. I am the Manager of Rate Setting Operations for the Office of Main Care Services.
Derek?
Good morning. I'm one of the managers within the Main Care Policy Unit, and I've been working extensively on the NF rate reform policy.
Bruce?
And good morning, everyone. I am Bruce. I am the Provider Relations Specialist, as you know, for Section 67. So now you finally get to put a face with the person you talk to.
Thank you. I don't know if Susan Allen's here.
No, she said she had conflicting information.
Okay.
I mean, meetings.
Right. Okay, and then Kathy?
Hi, yes, everyone. Catherine McGuire. Excuse me, my voice is a little off today, but I'm working as a consultant with the department and have been focusing on the PDPM patient-driven model work. Thanks.
Thank you. And I don't see Eris on the call, so I think that's it for introductions. Just want to check. Yeah, I don't see that on here. All right, so if you do have a question, we're going to jump right into it. If you have a question, please either enter it into the Q&A section at the bottom of your screen, or you can raise your virtual hand by choosing the raise hand option at the bottom of your screen. I will call on you in order of hands raised and send you a request to unmute your line so you can ask your question. For those participating by phone, you would press *9 to raise or lower your hand and *6 to unmute or mute your line. The chat feature is disabled. This is to ensure we don't miss any of your questions. And we will answer as many of the questions we can today. Any that we can't get to, we plan again to answer in an FAQ document that we will be developing or through direct email for registrants. Bruce is going to get us started with reading off questions that were submitted in advance and answering those. I don't think that'll take too long, and then we will get into the actual questions. Bruce?
Okay. And so, yeah, I'm just going to go over some of the questions that we actually got. And so the first one I have is, can we depend on the same payment process if we submit your claims by Wednesday or Thursday at 5 o'clock to get paid within that next 10 to 12 days? Yes, all the billing items and the processes will not change on there. So you will be all set. The only change that is occurring is you're going to be using the PDPM codes instead of your RUG codes. And another question was, can we reverse and rebill if needed? That is a yes. You'll be able to still do all the same processes with your claims, whether you need to reverse them out, reverse and adjudicate and edit those claims. And next one is going to be, can we edit claims when needed as long as it is prior to that Wednesday or that Thursday to update? Yes, absolutely. You can still go ahead and make any of those updates or changes to those claims. Is the process or the pay cycle, your wait pay, pay status, and deny, still going to all be the same? Absolutely. Those will still all be the same. None of those statuses change because those statuses are for all of main care claim services. And then we have in here, will a remittance be available the same time, same place, and look the same? Yes, that there will be no changes to any of the remittance advices. They will still be loaded up onto the portal as normal for you to be able to see and pull those down. And is there a sample of the UB, what the UB will look like with the PDPM implementation? There currently is not. And the only change that's going to end up being is the rug codes will go away, and it will show you that you just need to make sure you're using the PDPM instead. And then we have, will there be any changes to the revenue codes used for the claims, in-house hospital leave or therapeutic leave? There will not be any changes whatsoever to any of those other rug codes that you use, like for the room and board, for your leave of absence. Those all will stay the same. The only one that is changing is your 0022 with your PDPM HIPS code. And when will an updated 837I companion billing guide be available? Is there a draft version? The only change is replacing the rug codes to the PDPM HIPS code within the same area. There currently is no draft version. The only difference again is, like I said, with those changes is you're going to change out your rug code and input your PDPM HIPS code instead. And we have any immediate changes planned for Maine's portal? Enter in or transmit in any claims as a result from the PDPM implementation. And there is not any changes whatsoever that you will need to do enter in any claims on the portal. The only change is to be using the PDPM HIPS code. And like I had said before, we have this one again is will we bill the revenue code, two revenue codes, the 022 with the PDPM nursing component and the 0169 for the fixed rates? Yes, you'll still use those same ones. Like I said, any of the 0169, the 0185s, any of those items, those still all will stay the same, that you can put those on the same claim. And the last one that I have is the routine allowable reimbursement rate that should be identified on the claim line with the revenue code of the 0169. That the rate you will not change. That will be the same as whatever your rate letter will actually state of what you would be billing for. And that currently is all the questions that I actually had.
Okay,
Chris, we just
thank
had
you.
one more come in. It says, will we be using the same revenue code 0022 as they do for Medicare PDPM?
Yes, that is the same exact revenue code that you will be putting on your claims with the PDPM code, HIPS code.
Just
Any-
as a reminder, anyone,
Oh, go right ahead.
I see Janice has a question. Go ahead.
Hi. Can you hear me?
Yes.
Okay, so I just want to clarify the code that you are looking for with to go with the 0022 revenue code, because in the billing guidelines that you've posted, it has indicated that you want the main care PDPM code, which has the masked letters, which would be like, for example, AA for PTOT, SLP, and then you have your nursing component, and then another A, and then a 6, which is different than the Medicare PDPM HIPS. So can you please clarify, on the claim for revenue code 0022, are you looking for the CMS PDPM HIPS that is coming off of the MDS, or are you looking for the main care billing code that is in that billing guide?
Kathy, did you want to try and take this one?
Hi, yes, hi, Catherine McGuire again. Yes, what we are proposing to use is the masked code. The only character, that third character for the nursing component, is the actual nursing component that's generated by the PDPM. So with the 0022 revenue code, you will bill that masked code that's in the billing guide with the correct nursing group on it. Does that make sense?
Yeah, so because I think it's confusing when people say to use the PDPM HIPS, because people are used to like what the MDS actually produces. So thank you for clarifying that. And I do just want to comment that because that is different than what most states are doing, vendors will have to do development work to kind of account for this special state-specific code. So just wanted to mention that as well. Can I ask another question while I'm off mute? And that is, so it's my understanding through communication through the Maine Healthcare Association, they shared with me that they got some direction from the state that the state is also wanting that main care billing code to be inserted on the MDS in Z0250. And can you confirm if that is not a code that CMS currently accepts today? And so I guess I just need clarification if that is something the state is expecting.
Okay, thanks. Yep. Sorry, I couldn't unmute at first. My understanding is that when you put the main care billing code with the masked letters in the 250 area, the CMS MDS system will not be checking that field for quality assurance when you submit it, so that it should go through correctly on the system. So that is where we're asking that you can put that. It's an optional field. Thanks.
Thank you. Just for OMS staff, I did need to make you guys co-hosts so that you can unmute yourselves. So they shouldn't be a problem now going forward.
We had another question come in. Could you please speak to the plan for claims testing? We've requested end-to-end claims testing and have been told that isn't possible. That's part one. Bruce, do you want to take that? Or do you want one of us to?
So I believe that was from Angela. I'm gonna unmute her because she would like to speak to that.
Okay. Okay.
Hold on one second. There you go. You should be all set, Angela.
Great, thank you, and good morning. On behalf of the Maine Healthcare Association, I just want to say how much we appreciate OMS holding these office hours. I'm learning things as we speak and taking a lot of notes. So yes, Amanda, my first question was if you could please speak to your plans for claims testing. We've had some conversation with the department and understand that end-to-end claims testing is not possible. As you can imagine, though, with a transition to a new payment system like this, there are significant concerns about providers not being able to bill or being paid in a timely manner. So I'm wondering if the department could share what you're doing for claims testing, just to make sure internally that the new system will be up and ready to accept claims as of February. And then a follow-up question to that is what is the department's plan for backup, whether that be bridge payments or a plan B in the event that the new system doesn't work properly? And thank you.
Sure, I can answer that. So we have covered there is end-to-end claims testing isn't something that's typically done at the department level. And also within the time constraints that we have currently, it wouldn't be possible or feasible. Our vendor will be running claims testing as like a trial without involving providers. So they'll use real profiles and run claims to ensure that the system is working. So you have that verification. And then providers are encouraged to run claims up to the point of submission with their respective software vendors. The good news too is if there is a denial, if there is an issue with a claim, you don't have to hold until a whole batch of claims submission the next month. You can submit as soon as the next day, and our staff is ready to answer any of those questions and work through issues with providers as they come up. So I'm sure you know your PR very well. So don't hesitate to reach out if you do encounter issues.
Thank you, Amanda. I guess just that follow-up question is what is the department's backup plan? I think there have been situations in the past, certainly long before my time here, where transitions and systems didn't go exactly as according to plan. So we're, again, just looking for some assurance that providers will have some opportunity for cash flow.
Sure. Yeah, I mean, we really don't anticipate that being an issue. I know that, when money's on the line and you're trying to make sure that you have cash flow to run day-to-day operations, you want to know that there's a firm plan. I mean, there are mechanisms if need be, ways that could be worked out. But at the moment, there's no need to there's no reason to think that the system won't go off without a hitch.
Thank you for your response. I guess, again, I would just say respectfully, I'm not sure that there's assurances in providers' minds that it will. So I guess we're all kind of taking a leap of faith here together, and fingers crossed it all works.
Yeah, I understand that. It is a stressful position to be in, and sometimes that is a leap of faith. But I think that the partnership between Maine Healthcare Association and the department has continued to grow. So just keep those channels of communication open. You're great at reaching out on behalf of all of your providers. And so we'll just continue to keep the channels of communication open should anything arise.
I would just add in that I believe that if there is an issue with providers being able to bill or something going wrong as part of the implementation, I don't think the department would be unwilling to revisit that idea and look for alternative measures to not have providers in cash flow issues as we transition to this new payment system.
Thank you both. I appreciate that. I'm all set. I'm gonna let other people talk now.
Thank you.
Thanks, Angela. And we've had a few come into the Q&A. When will rate letters be sent out? Will they state clearly the fixed rate?
The rate letters should be uploaded to the portal today.
They are already uploaded.
All right, so they are already uploaded today. It does break down and state both the direct care rate, the routine rate, and the fixed cost rate. It does combine the routine and fixed cost rates into one single rate as part of the 0169, like the previous methodology.
Thanks, Dwayne. We had a clarifying question come in. When you say proposing to use the masked codes on the UB04 and in Z0250, does that mean that that is not the final decision? Vendors need to program for this, and we cannot do so without final specifications. I've unmuted you, Kathy.
Yes, at this point, that is our final decision to move forth with those codes.
Will you be documenting the MDS requirement for Z0250 and publishing it publicly? Kathy, I unmuted you, but I can take a crack at that and you can correct anything
Okay.
that doesn't sound right. We do plan on posting these Zoom calls to the rate reform page, and we will likely develop an FAQ document as a result of this. So thank you for contributing some great content for us to use to develop an FAQ document. Yeah, that would be posted to the rate reform page too.
And I don't think there's been a timeline associated with getting that part done yet.
Yeah, it wouldn't
my
be until at
understanding.
least after the second office hours call, so that's one consistent document.
Oh, and I'm reading the next question, I guess, but in terms of what's the timeline that main care billing HIPS needs to be inserted into the MDS? And there's not a proposed timeline at this point. So more will be revealed, I guess, as we get further along.
All right, the next question we have in the Q&A is, will the rate letter information be posted on the rate setting site in section 67 folder?
Yes, the rates, like they have been any other year, will be uploaded to the portal fee schedule, as we do with as we have done with all other rate letters that have been published.
The next question, will the direct care add-on rate, and then in parentheses, fixed rate, revenue code 169, need to be listed separately on the claim as it is today?
Yes, that's still all the same. None of the current billing will change with those other revenue codes.
And Mandy just put the link to the rate reform page in the rate reform website in case you don't already have it. It's good to favorite that. There's a lot of great information on there. Y'all are great at using the Q&A feature. A lot of folks struggle with that. You're welcome to come off mute as well if you want to pose a question verbally, or you can keep using the Q&A feature. At the moment, we don't have any outstanding questions.
Hi, this is Karen Flanagan. So I'm looking at the rate letter, and I'm looking at the prior setup. So with the reimbursement amount for the building, we had a rate, and then there was a fixed revenue code of 0619. On the rate sheet for direct care, routine care, capital costs, what are we putting in for that quote unquote reimbursement amount now for the 0169?
Are you asking me what the rate is for the 0169 compared to the old letters?
Yeah, which, okay, right. So which I'm looking at direct care, routine care, or capital costs. What am I putting in for that? The
Well-
fixed rate portion?
Are you looking at the old letter or the new letter?
I'm looking at the new letter.
So you have a routine rate broken out on that letter.
Yep,
You also have you have a fixed cost rate broken out on the letter.
yep.
And then you have a combined for those two rates that is the total of the 10169 code.
Okay, so say that the direct care and the room, oh, I'm looking at the letter itself because I was looking at the second page. So again, I'm sorry, can you go over that again?
You have the routine rate listed on the letter, and then
Yep.
you also have the capital cost listed on the letter.
Yep.
Then you have a combined rate at the very end of the letter of that calculation that is the combined rate for the 0619 bill.
Oh, I don't have a combined rate. I don't see total room and board rate. Is that what you're talking
Yes.
about?
Yep.
Yes.
Yep.
Perfect. So it's under the capital cost. Got it.
Yes.
Thank you.
Yep. You're welcome.
We had one more question come in. Are there any changes to the DAP or TBI rate?
So the days awaiting placement rate will be updated July on the July schedule still. And then we have not, so I'm not familiar with which TBI rate we're talking about here.
We're in process of developing rate reform for the specialty units, both brain injury and the med psych units. So there will be updates to that. We're expecting that to roll out in January of 26. So stay tuned. Oh, we have one more. Oh, no, we did that one. Other questions, rate off or clarification on any of the questions, maybe from the ones that Bruce answered right out of the gate? Was there any clarification that anybody wanted on any of those? Would it be helpful if we shared the PDPM billing guide and went over a little of that and see if folks have questions related to that? Do you have that handy to put up, Derek? Okay. And again, that the PDPM billing document is available right on the rate reform website. It was also sent out in an OMS message, and I believe Maine Healthcare Association distributed it too. So everybody should have this now. I'll let Bruce or Kathy take it from here if there's anything you want to point out. We did just have another question come in. I'll read while we're getting through that. What is and it's related to this, so perfect. What is the reasoning for using the masks for the HIPS codes versus ignoring the non-nursing components as other states have?
So I can jump in and answer that one. With the rate system that we've developed and the guardrails that we've included, to incorporate that into our billing system, we would have had to create tables that are provider specific that include 15,000 codes and upload all those codes to the billing system to pay out correctly. That was not feasible in the amount of time, given the amount of time it would have taken Gainwell to update 15,000 codes for 79 different providers. That is why we went with a single 26 codes that map to the rates on the table to get those updated in the system for billing purposes.
Thanks, Sween. I hope that answers your question. I think it's a minimum of 15,000, and with the exponent or whatever, I think it could have been up to like 29,000. So incredible amount of data entry. Kathy or Bruce, did you want to just kind of maybe peruse through and give like an overview of the PDPM billing guide? And I know Derek's sharing, so thank you, Derek. If it's hard to know where to be.
Hi, we tried to put together something that would help translate, how you get the information from the MDS to the codes that would be used for billing. And so we basically at the top here are just reiterating, the use of the mask with the 0022 revenue code, that the only character that we'll be actually looking at towards that is the nursing payment group. And also the requirement for the type of assessment to be a 6, an over assessment. And then we walk through various scenarios of the timing of the information on the MDS with the timing of billing. Quite frankly, I'll just put forth that between myself, Stu Panett, and Karen Mooney, we constructed these. And of the three of us, Sue Panett and Karen Mooney are the better at the timing of the requirements for the assessment. So I'll try to just share that with you right off the top. But so starting on pages 6 in the document, we talk about that transition and transition relative to how it aligns with your MDS assessments. So any services billing on or after January 1st, 2025 will use this PDPM mask code for billing. So clearly there's going to be overlap with what you're completing for assessments in the facilities today and with the timing, such that for some, right, the OSA assessment will still be getting completed so that you get a RUG code so you can bill for services up through 12/31, right, 12/31, 2024. And then after that, from just the OBRA assessment, you'll be able to obtain the PDPM groupings. So we walk through various scenarios there, which hopefully will cover most cases of what would be how you would basically go about billing. We use that 92-day window for assessment timing as our reference points. And so tried to put together during this transition time what assessments would be used for what time periods, et cetera. So they're fairly detailed. And again, if there's something that we have missed, it would be great to have that pointed out to us. But we also, try to bring up the like when a discharge is happening, when somebody is gone to the hospital and coming back, return reentries. Yeah, and just a variety of scenarios of how that would then translate into your billing. So I don't know if anyone has specific questions on this. Like I said, I'm a poor substitute for Sue and Karen on this front. But we can always take questions back and get back to you. So I think there's one in the chat.
Yeah.
Using just the nurse. Yep.
The question
Okay.
is, using just the nursing component is similar to other states. And I understand that logic there. The question is, why bother masking the other components with the A rather than disregarding them entirely?
It's a good question. I think our intent was trying to have basically a valid HIPS code, but that the state is still ignoring those other characters and just billing off that B code.
Just using like as a placeholder.
Yeah. Because otherwise the suggestion, I guess, is why didn't we just put, like in our example here, just have a B sent in that procedure code.
Other questions related to the PDPM billing guide or any other billing questions for Kathy or Bruce or the rest of the team. I will mention one question that came in, and I don't think that made it to the list of questions because we answered it via email, but just for clarification, a notice went out recently regarding holding January claims. So in case there was any miscommunication there, we're just asking that you hold the claims from January 2025, this month that we're in right now. So hold those until February 1st. So a lot of folks don't do their billing until February 1st anyway. That was more directed for like the weekly billers, and there are a few of those out there. We anticipate the system will be ready to go by February 1st, and Mandy will be sending out a notice when it is. So you'll be getting a notice when it's completely ready to go live. If you have December claims, still left over, you can certainly enter those in the old way, with the rugs. And they won't be denied. So just to clarify, we're not asking anybody to hold claims beyond February 1st, but we will send a notice out letting you know when everything's ready to rock and letting you know to start submitting claims. There's a couple more that popped into the Q&A. Oh, this is great. I may have missed it, but where can we get a copy of the billing guide? So, Mandy, do you want to take that?
Yeah, I thought I had put it in the chat, but no, I did not. So I will put that in the chat. And then there was also a couple of chat messages I got. If there are questions after this call, to whom should we direct them to? And where will this recording be posted? I did post the link to the rate reform website in the chat. If you scroll up, you should see it. And it will, if you go to the in progress section and scroll down to the nursing facility section, there's a lot of presented materials and e-notice links in there. Go to the very bottom, it'll be right there. And then if you do have questions after this call, Amanda is going to be compiling.
Feel free to send them to me, right where the notice that Mandy sent out. My email is right in there. It's amanda.nelson@maine.gov, and I'll make sure it finds its way to the right person. And it very well could end up in the FAQ document as well. Any new questions that roll in, we will answer them in the next session. If it's something urgent, I'll make sure that you get to the right person who can answer it quickly. If it's a rate letter question, Dwayne is definitely the best person to reach out to. His name and contact are right on the rate letters. I have another question here. Is the state communicating with approved software vendors? That's a great question. So the state, I got from Sue and Karen, and Kathy, correct me if this is wrong. They will answer questions that are coming in from software vendors, but they're not going out of their way for like mass communications with their software vendors the way that we do with the main care providers. So we rely on the providers to cascade that messaging out to the software vendors if they have specific technical questions or something like that, and you're having difficulty answering it with the messaging that has gone out. I know Sue does often field some of those, and sometimes Bruce as well, and the other PRs. The next question I see, what will happen if the true HIPS is sent on the claim rather than the masked code, as it is essentially being ignored anyway?
So you won't be, the claim will not pay if you do not use the masked HIPS code. If the system uses a table, which is on the back of your rate letter, and the table pulls using that code to pay the rate after it's case mixed. So the only HIPS codes that have rates attached to them are the ones that are included in the third page of your rate letter that we've established.
Thank you, Dwayne. Mandy just put some more great links into the chat. The main care rate reform site again. a direct link to the billing guide, which is also on the rate reform site, but this skips right to it. And then she entered my email, should you have more questions, and I'll compile them for the next session. The next session will also be posted on the site, the recording, and we'll use those questions to continue to formulate an FAQ. What other questions do you all have?
Can I share my screen real quick, Amanda?
Oh, that'd be great, Dwayne.
So I just want to put this up here for those who haven't seen it yet. Can you see my screen?
Yes, we can.
It's showing the rate letter. So this is the new calculation sheet. I can see where there was confusion on the previous question, as both the routine rate and the total room and board rate are highlighted. If it's helpful, the rate setting team can work on putting the revenue codes in the line with the corresponding rate that should be billed on the claim for future letters. But for those that have not seen it yet, this is what the new rate letter calculation sheet looks like. So it has the breakdown of the guardrails and the percentages. And then the logic is also written in there to help follow where how the calculation's applied. And then flows down, as I said before, with the routine and capital cost to that bottom rate, that's the 0169 room and board rate. Additionally, this is the new table that's replacing the rug table that was on the pages 3 and 4. I think it's 3, 4, and 5 are the old letters, listing the 26 HIP codes, the groups, descriptors, and it has the VVP portion for in future years that'll show the amount of the withhold and the impact on the rate. So this is the new format that has been rolled out in the new letters. If you do have feedback on stuff that's confusing and changes you'd like to see to them that make things more clear, please send them to me as the rate setting team has developed the rate letter generator themselves. We'll continue to update those if needed moving forward.
Thanks for sharing that, Dwayne. I know the rate setting team went to great lengths to try to make it as clear as possible. While we have a little lull, does anybody, maybe if you've accessed your rate letter, we can't talk any, facility specific information, but if you're curious about the calculations or anything like that, if anything needs clarification, yeah, you have a great audience. Dwayne's pretty good at explaining it if anyone has questions related to that. It looks like we had a new question come in. If we have retro billing that is partly the old system and partly the new, can we do this?
I don't understand what you mean partly the old, partly the new, but if you're saying you have claims for multiple months that are going to pay off different methodologies, my conversations with Gainwell is that is going to be something that you can do. The rug system will still be available to be billed for all the time periods in which the rug system's been in place, and is just being end dated on 12/31 when the new system picks up on 1/1/25, the new billing system. So because both are still live for set time periods in the system, you should be able to bill both old claims and new claims if you do so to receive those payments.
Does that answer the question, or does anybody have any clarifying questions around that?
Yeah, feel free to raise your hand or come off mute. I'm not sure at this point which way it's working, but I don't see any raised hands. You might be able to unmute yourself. If you.
We did just get one more in the Q&A, but like Mandy said, don't hesitate. If there's silence, we'll go right on to the next one. But if you want to back up, don't hesitate to raise your hand or type it in. The next question, do we bill the default PDPM code ZZZZZ on the 0022 revenue code line for bed hold days? This would be in addition to the room and board rate on 0169 claim line.
So currently, do providers bill? Because my understanding is that the department only pays out the room and board rate for bed hold days, and they do not pay the direct care rate for bed hold days.
That is
Is that-
correct.
Yeah, so I mean, I would imagine you'd keep the same billing system that you would for bed hold days that we currently have, as those rules will still apply, as far as what the department pays for bed hold.
Kathy, did you have something to add there too?
Well, I was looking for modified UB billing instructions because it is like they just have said, it stays the same. I don't believe that there was any billing up for a 0022 revenue code on the days waiting, bed hold days, but I would want to confirm that with the UB instructions, so unless Bruce knows right off the top of his head.
No, there has not been any change to
Any
use a
change.
0022 for any bed hold. You still use that same revenue code that you currently use.
If there's a question you've been holding on to, now's the time. Any clarification questions? Would it be helpful to put the PDPM document up again? The rate letter example that Dwayne shared. So it's really a Q&A session. If you don't have any other questions, I can't promise any of us will sing show tunes. We can just wait. Is anything from the team? Is there any other points that you would like to share that weren't addressed? Would it be helpful, Mandy, what do you think about pulling up the rate reform site?
I just got a
Scrolling down.
request, someone requested reviewing the rate letter again.
Oh, okay, great. Wayne will pull that up. He's just finding it. Were there any specific questions on the rate letter, or did you just want to view it? We've got a few minutes left. I know the guardrails can be a little confusing. So it's great that the team put the guardrails right on there.
It's fine, Dwayne. Yeah, we've just, every now and then Zoom does an update and then we find these weird things that go on, like this black floating thing.
I have a feeling folks will have more questions on the next office hours too, once you get to really dig into the rate letter with your team and start to kind of try and parse it out, pull it apart.
And you know how to contact me as well. So
Speed
that's
dial,
all
right?
good. Yeah. Speed dial, email. I'm here. I have never seen this group so quiet.
I think you can stop sharing, Dwayne.
Yeah.
Thank you. All right, we got 3 minutes left. Did you want me to wrap up, Amanda, or did you want to do that?
Yeah, take it away. I thank you everybody for jumping on and for such great questions. It's been really great. But yeah, Mandy, take it away.
So as we said before, we're working on an FAQ that will be developed and shared towards the end after our second open office hours, which is going to be on the 28th at, I believe, 11. Additional questions can be sent to amanda.nelson@maine.gov. The rate letters notice should go out today or tomorrow, but as you know, they've already been posted. And then, yeah, make sure to check the rate reform site this afternoon probably, or tomorrow morning for the recording of today's meeting. And I think that's it. We appreciate everybody joining and contributing.
Thank you. This was very helpful. We really appreciate it.
Thank you very much.
You're welcome.
Thanks,
Thank you, everyone.
Bye.
Bye-bye.